Hey everyone, welcome to This Explainer. Today, we're diving straight into an intensive clinical review to really help you nail that musculoskeletal exam. We're going to focus on exactly how to spot the difference between true joint disease and all those tricky soft tissue issues surrounding them. Let's get you those high-yield tools you absolutely need for everyday practice. So, here's our game plan for today. We'll start with articular versus periarticular pathology, move into shoulder disorders from tendons to capsulitis, tackle elbow and wrist tendinopathies, look at hip and knee bursitis, and finish up with heel pain and plantar fasciitis. All right, section 1, articular versus periarticular pathology. Musculoskeletal complaints make up something like 25% of all outpatient visits, but here's the crazy part. A huge chunk of those have absolutely nothing to do with the actual joint itself. So, here's the golden rule of our diagnostic funnel. You've got to distinguish articular structures, think synovium and cartilage, from periarticular tissues like your tendons, bursae, and ligaments. And how exactly do we do that? By being super precise when testing both active and passive range of motion. If someone has a true articular disorder, they're going to have pain on both active and passive movement, usually with some deep, diffuse swelling. But if it's just a periarticular issue, that pain typically only shows up on active range of motion. Plus, you'll usually find focal point tenderness right over a specific anatomical structure, rather than that generalized, puffy joint swelling. Okay, take a look at this. This is a perfect example of osteoarthritis. A classic, true articular disease. See that intra-articular cartilage degradation and bone invasion? When that cartilage wears away completely, you get bone grinding directly on bone, and those osteophytes start popping up right inside the joint space. This structural breakdown physically restricts both active and passive movement. It's a literal mechanical block within the capsule itself. That deep, diffuse restriction is a totally different beast than, say, a localized tendon strain. Moving right along to section 2, shoulder disorders, from tendons to capsulitis. Let's take this active versus passive rule and apply it directly to the upper extremities, starting with the shoulder. To put this into perspective epidemiologically, almost 30% of elderly patients who come in with shoulder pain have a rotator cuff tendinitis or tear. 30%. It's incredibly common, and the great news is that your physical exam skills can isolate it beautifully, often without jumping straight to expensive imaging. So picture a 65-year-old patient walking into your clinic. They're wincing just trying to reach a high shelf or comb their hair. The absolute key here is how this pain behaves mechanically. Rotator cuff tendinitis, especially in that supraspinatus tendon, which loves to get pinched under the acromion, causes severe pain when the arm is actively abducted. Specifically, it hits right in that 60 to 120 degree arc where the subacromial space is at its absolute tightest. But notice this. The pain flares up on active overhead motion if you tell them to just relax their arm and you move it passively for them. The motion is usually fine and way less painful. That right there is a textbook example of periarticular behavior. And you can actually diagnose these impingements and tears dynamically, right at the bedside. Take the NEAR test, for example. It is absolutely critical that you stabilize the scapula first. I mean it. If you don't lock down that scapula, the patient is just going to shrug to compensate, and you'll miss the diagnosis entirely. So hold the scapula down and force the patient's arm into forward flexion. If they feel pain before hitting 180 degrees, boom, that's a positive sign for subacromial impingement. Now, what if you suspect a full thickness tear? That's where the drop arm test comes in. Have the patient slowly lower their fully abducted arm. If they can't smoothly control that adduction, if the arm literally just drops or gives way, you are very likely looking at a rotator cuff defect. But wait, what if both active and passive motions are restricted? Well, then you might be dealing with adhesive capsulitis, commonly known as frozen shoulder. Pathologically, what's happening is the glenohumeral capsule gets thickened, inflamed, and intensely fibrotic. It usually sneaks up insidiously, though it's strongly linked to prior minor traumas or systemic triggers like diabetes and thyroid issues. We generally see a gradual progression of this capsular contraction, and we match that with a step-up management plan. You start with physical therapy and local intra-articular glucocorticoid injections to cool down the inflammation. If they're still stuck after a few months, we step it up to contrast hydrodilatation to actually stretch the capsule from the inside, or maybe even consider manipulation under anesthesia to manually break up those adhesions. The wildest part, though, for most patients, even the really severe cases will eventually resolve completely on their own over 1 to 3 years. All right, let's head into section 3, elbow and wrist tendinopathies.
As we move further down the arm, we have to talk about repetitive twisting. Those motions can seriously inflame the tendon sheath right at the radial styloid, giving you de Quervain's tenosynovitis. And there's a fantastic way to definitively confirm this localized inflammation, the Finkelstein test. Actually, go ahead and try this 3-step maneuver right now, wherever you're sitting. First, put your thumb inside your palm. Next, close your fingers tight over your thumb to lock it in. Finally, ulnar deviate your wrist. Basically, bend it away from your thumb down toward the pinky side. Feel that pulling tension? That localized stretch over the radial styloid is exactly what your affected patients are feeling every single time they turn a key in a door or lift a frying pan.
Now, as we transition from the upper body down to the lower extremities, we really need to pause and ask a fundamental mechanical question. How does the sheer, constant force of weight bearing alter the clinical pathology and the tissue stress response we're seeing in these joints? Let's explore that in Section 4, Hip and Knee Bursitis. Our lower limbs take a massive mechanical beating with every single step, and that leads to microdamage and inflammation in the bursa. Remember, these are the little thin-walled, fluid-filled sacs that cushion our tendons against bony prominences. Think of this breakdown as your high-yield clinical speed round. It's going to help you instantly pinpoint specific lower extremity bursitis based purely on anatomy and whatever activity makes it worse. For instance, ischial bursitis hits at the base of the pelvis from sitting way too long. Prepatellar bursitis, often called housemaid's knee, flares out from repeated kneeling. And anserine bursitis, which sits just below the medial knee joint line, is a classic culprit for pain when a patient is climbing stairs.
And then there's trochanteric bursitis, which is an absolute classic masquerader. So many patients will come into your clinic complaining of vague hip pain, which immediately sounds like a true articular issue like hip osteoarthritis. But if you do a thorough exam and find focal point tenderness directly over the lateral posterior side of the greater trochanter, and especially if that pain spikes when you test external rotation or resisted abduction against your hand, you've nailed it. That is periarticular bursitis. True hip joint pain, by contrast, is almost always felt deep in the anterior area, like over the inguinal ligament or straight in the groin. Finally, we're down to Section 5, heel pain and plantar fasciitis.
Down in the foot, things like unforgiving running surfaces or flat arches create this immense, relentless mechanical tension, and that gives us some of the most stubborn periarticular conditions out there, the biggest one being plantar fasciitis. The absolute clinical hallmark of plantar fasciitis is this intense, agonizing pain right on those very first steps when getting out of bed in the morning or after sitting for a long stretch. It's super easy to diagnose just by finding point tenderness directly at the calcaneal attachment on the bottom of the heel. Oh, and we definitely can't forget Achilles tendonitis here either. That typically presents with posterior heel pain and a physically thicker, swollen tendon, usually flaring up after someone suddenly ramps up their running volume without conditioning. So how do we treat these lower extremity issues? We always follow a strict step-up management plan. You start with the basics: rest, ice, and mechanical support, like orthotics or heel cups. We really only move to NSAIDs for acute flares. But listen up, because this is a massive clinical pearl. While local glucocorticoid injections are an awesome, standard go-to for upper extremity issues like the shoulder, you have to be incredibly cautious in the lower limbs. Injecting anywhere near those lower extremity weight-bearing entices, like the plantar fascia or the Achilles tendon, carries a downright severe risk of triggering a catastrophic tendon rupture. Just don't do it. This brings us to a really vital, overarching theme. A masterful, targeted physical exam will very often beat out expensive imaging when you're trying to track down the true source of a patient's pain. When you truly understand the local anatomy and can confidently tell if pain is triggered by active versus passive motion, you are saving your patient time, money, and a whole lot of anxiety. You're jumping straight to a diagnosis they can actually act on. So, the big question I want to leave you with today is this. If your patient's passive range of motion is totally normal and completely pain-free, but their active motion hurts like crazy or is severely restricted, are you going to trust your exam skills? Are you ready to look beyond the joint capsule itself and uncover that hidden periarticular pathology? Thank you so much for joining me for this explainer. I really hope this framework totally transforms the way you approach your clinical musculoskeletal exams.